Assalamu alaikum. Today we're very lucky. We had a lot of undercuts today. So we're going to complete the demo around them. And this is another case of exostosis. Notice if I look from upwards, if you bring the camera from this side, you see that this is an undercut. See how my finger disappears in it when we look from the occlusal. So these are exostosis. How do I know they're exostosis, not natural undercut? As I told you, they are close to the teeth. They are C-shaped. And they are all over and irregular. They're not like the natural undercut that we have. Notice that, once more, this is a case where we have encirclement. If you see the previous videos, you will know it, but let us concentrate on it. See how the undercuts are present anteriorly. They're going to the lateral. If I shift like this, see them under the premolar. Even under the molar area, there's an undercut. Okay? There is a bony undercut here. Okay? See it? And then even we go buccally, and this is not an area of undercut. In this case, there's a very slight one. But more than that, lingually to the teeth. This is all an interaction of soft tissue and bone to periodontal disease. Look here. I have a large undercut here, other than the lingual undercut that's naturally present, because you know the body of the model, it flares outside. So this is the body of the model going outside, but this one here is from the exostosis, okay? We go into here. See this sharp bony specule here? Okay? And it's going to the other side. These are they tori? Okay? They could be, these two could be tori. Okay? But other than that, how could I have lingual undercuts like here? Okay? So one here, it's very close to the ridge. All of these are exostosis. Now, what do we mean by encirclement? That these undercuts are going like this, and these undercuts are going from the inside. This is more than 180 degrees. What will happen if I put the material and solidifies? I cannot remove it.
Can't remove it.
Okay. In the previous slides, we talked about options for impression material and what we do with secondary trays. In this video, we're going to talk about surgical reductions. Okay. In some cases, these undercuts, if I could not place a denture because this undercut is opposed by this undercut, they're totally opposite. What should I do? There are multiple options. One of them are surgeries, where I could open a flap and shave the bone, the compact bone, osteoplasty. I change the shape, where I remove the bulgy areas that are opposing to each other. Look at this sharp one here, for example. See this sharp one? And it's opposed by this one, lingually. So these are very opposite. And if I'm going to put a denture in and out, it will be traumatizing for the patient. What other option do I have? I have an option. Change of pathway session will not shift. Do you know why?
Material.
Even material, because dentures are solid. I could change. Of course, I'm going to change impression material.
Yes.
I know I'm going to do that. But how I'm going to do in the denture, more relief. But even though, why not in the cast, as a cast, when we take the secondary impression, on the cast, I do blockout. So the denture, I will not let it enter all into the undercut. I'll let it enter smoothly into the undercut. I will not let it go under the shelf immediately, like these areas. Okay? I will not allow the denture to go in the shelf areas here just immediately. I would make it smooth, running over the bulge of the crest to the sulcus. So how do I do that? By blocking all of the undercuts on the cast. Okay? Using on the stone, I use some blockout material using a stone. So I eliminate these undercuts. So the denture will go into an undercut, but not immediately on the shelf area. It will go smoothly from here down here, diagonal, without go into the undercuts. There is another way, which is totally making the denture parallel, not at all going in a undercut direction. And this we could do it, especially in the lingual areas. But in this case, I would recommend surgeries. Okay? Or, because this patient had cancer and he had some treatments for cancer, I'm going to recommend that he's going to do without surgery and go for relief. But the denture there will be a lot of space beneath it. Okay, so we will give him a lot of instructions about the hygiene. Now look at the upper, the same case at the upper. Undercuts all around. See how severe the undercuts are. They are C-shaped immediately beneath the teeth where the teeth were. See. Here they are opposite to each other. They are extending to the premolar area, molar area even here. I have in the molar area, and around the tuberosity and going to posteriorly. This is encirclement. Once more, these undercuts are opposite to each other, I need to either relieve them by surgery, relieve them by surgery where I reduce, especially in the molar areas and around the tuberosity, or I relieve the undercuts, I block them on the casts and utilize only one side of the undercuts, not both sides. So I would relieve one side of the cast and let the denture use the other side of the undercuts, okay? Or if they are so severe, I might relieve both sides. Just leave a very minimal undercut engagement with the denture. Once more, in this case, if I do a lot of relief in the denture, we will have a lot of spaces between the adaptation tissue, the tissue and the denture, and the hygiene should be meticulous for these patients. All of these are options on how to deal with undercuts at the denture level. The previous video talked about the impression level, and before that at the primary impression, and the reasons. But this video concentrates on the solutions. Thank you.